come in.
Yeah.
Okay, everyone. So I'm just
We have to wait. Everybody's
sorry. I'm just I'm gonna start sharing the title screen because we're gonna go live on YouTube in a few minutes because someone else needs the link we'd like to disseminate. So please go on with your conversation. I just wanted to let you know.
It's okay. We're just warming up.
Yeah. It's nice seeing you, Sister Shifa.
I know, it's so nice to see you as well.
Yeah, I see you only on the picture on WhatsApp.
Sorry. I'm just I'm gonna post the
that's me
sharing
again.
the title. Sorry, there we go. We're getting double chats with the Zoom link.
Shifa is an amazing asset to IMI.
Thank you so much.
Assalamu alaikum, everyone.
Welcome, Sam.
Hello, Dr. Zaidi and Dr. Mubarak. Assalamu alaikum.
Assalamu alaikum. Really good to see you.
Good to see you as well.
Assalamu alaikum.
Assalamu alaikum.
Okay, I'm just gonna call Dr. Arastu and Dr. Askar, and then I'll be back.
Yeah.
What's the weather like in London, Dr. Zaidi?
It was 1 degree to start off with the day, so this is what I'm not sure what the conversion in the US is. It's early spring, so early spring essentially is an extension of the winter, and it's always cold and rainy, so it's not too bad.
I studied in London, so I know London, but I love it anyway.
All right. So I'm based in Liverpool, which is up in the northwest.
Okay.
And the weather generally is a bit colder up in the north.
So are you vaccinated?
Yes, very early on, actually.
How about you, Dr. Mubarak? Did you get your vaccine?
No, not yet, actually. So here, because I'm not practicing in a hospital, I'm working in the industry. So I was not part of the first priority. Now, of course, they've made it available to everybody above 45. And I am eligible. But we are facing a little bit of shortage of vaccines in Mumbai this week. Next week, it'll be back.
So you're not taking the Indian one, I hope. You're taking the AstraZeneca?
So, yes. So the two versions available here are the AstraZeneca one and the one from Bharat Biotech, which is Covaxin, Covishield and Covaxin.
Yeah, my sister who lives in Chennai took the Covishield.
Yes, that's what majority of the people are taking because that has more data in the public domain than Covaxin.
The Bharat one is, yeah.
Yeah.
Okay, I think I'm in. Yes. Okay, it's working. Great. Okay, thank you.
Perfect. So I think everyone has joined us. Dr. Ishaq was with a patient, so he's going to be here in like 2 minutes. Now we have our attendees joining as well. Dr. Izzi, we just want to test your audio and video if you can also.
Assalamu alaikum, everybody.
Wa alaikum salam.
Assalamu alaikum.
Assalamu alaikum. Can you hear me?
Yes.
Assalamu alaikum. Shifa, just wanted to test my audio as well. Are you
yes, thank you, Dr. Asghar. Perfect.
Great. Thank you very much.
So Shifa, I'll stop my video, right? So that when I come on, I'll turn it on.
Yes, that's whatever you feel most comfortable with. I'm just going to highlight the two moderators when they begin, and then once they introduce you, you can come on. Okay, and then just a note to Dr. Yemal and Jamana, at the bottom, like towards the right of your screen, you'll see the Q&A box. Okay, so that's where most of the questions will come in.
In the chat, is that right?
No, they're in the QA. I'm going to disable the chat so everyone has the Q&A box to write from.
I see. Okay.
So everyone's they all know to go one way.
Shifa, can I just mention I'm going to share my screen?
Perfect. And you should, all the panelists should be able to. So I think only Dr. Ali Asgar's, I'm going to share his. Dr. Arastu doesn't have, his is lecture based. Dr. Mubarak and Dr. Wahida are also going to share their screens.
Dr. Elias, but can I also share my own screen if you allow?
Yeah, that's no problem.
Great.
That's
Great.
perfect.
Thank you. Thank you.
Thank you. So just a few more minutes to go, and then inshallah we can begin. Welcome, Dr. Rastu.
Yeah, Assalamu alaikum.
Walaikum salam. Okay. Inshallah, you can take it away. I'm gonna mute myself and then you all are in charge.
Shifa,
Yes.
Dr. Wajid will open. Just
Perfect.
FYI, we made a little modification there.
Perfect.
And then Jamana will start. Inshallah.
So Dr. Rizzi, if you can begin, inshallah.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. It is a tremendous pleasure to welcome you all at IMI's Ramadan Fasting and Diabetes International webinar. We are grateful to Heather TV, through whose cooperation we are reaching out to hundreds and thousands of viewers worldwide, especially in India and Pakistan. The event has also been relayed at IMI's YouTube channel and Zoom links. We have a galaxy of experts today who are going to dissect the topic in minute details. We are very grateful to our international experts and faculty who have taken the time out of their busy schedules to render their expertise for the international audience. Each presenter will present for 5 to 7 minutes. That will wrap this up in 35 to 40 minutes of the presentation, followed by a robust Q&A. The moderators for today's event are two very bright and emerging leaders in our community, Dr. Yamal Al-Maki, who did her fellowship in endocrinology and metabolism from the State University of New York at Stony Brook in 2012, is a practicing endocrinologist in Bethesda, Maryland. She practices entire spectrum endocrinology and is a leader in diabetes and health education in her region. She is joined by Sister Jumana Jaber, who after completing her bachelorate in biomedical sciences from the International University of Lebanon and serving in Kuwait, is currently completing her master's in cardiovascular research at the University of Göttingen in Germany. Ladies and gentlemen, Holy Ramadan is around and is the 9th month of our lunar calendar. Fasting is one of the major pillars of Islamic practices. According to the latest estimates, there are more than 463 million people living with diabetes around the world. this will reach to almost 700 million people by 2045. The numbers are going to be almost doubling, especially in the Muslim populated regions of the world, such as Africa, Middle East, and Southeast Asia. A recent survey from 39 countries shows that 93% of Muslims do fast, of which 43% of people with type 1 diabetes and 79% of people with type 2 diabetes fast for 15 days or more, and 69% fast for the entire month of Ramadan. This international webinar we are bringing today would highlight the importance of diabetes in Ramadan education. Our experts would analyze the different facets and address the practical, clinical, psychosocial, and behavioral aspects of Ramadan teaching and the care needed during this holy month. Without further ado, let me hand this event to our two bright moderators, Dr. Yamal Al-Maki and Jumana Jabir. Thank you.
Assalamu alaikum. I would like to thank Dr. Wajih for his warm introduction. We welcome physicians, healthcare practitioners, and patients and their families to the annual International Diabetes and Ramadan Fasting Panel discussion. Diabetes is a complex disease, and at the same time, and the same management does not apply to every patient equally. In other words, every diabetic patient is at a different stage in their medical condition. Because there are about 148 million Muslims that will be fasting this year, it is necessary to bring to light the guidance for the management and treatment of diabetes. I would like to give this also now to Dr. Yamal, please.
Assalamu alaikum. I'd like to thank you, Dr. Wajih, for the introduction, and thank you, Jumana. A warm welcome to our esteemed panelists and our audience from around the world. As mentioned, we will have 5 panelists today who will be speaking for about 5 to 6 minutes each. Jumana and I will introduce each panelist, and we will follow the order with first Dr. Raza Zadi, who will be providing an overview of diabetes and discuss risk stratification. Next will be Dr. Ishaq Arastu, who will discuss the physiology of fasting and feasting, as well as fasting in pregnancy. Dr. Wahida Karm Ali will discuss the risk factors, including hyperlipidemia and hypertension. She will also elaborate on diet and exercise while fasting. Dr. Ali Asghar will discuss the management of type 1 and type 2 diabetes for patients who decide to fast in the month of Ramadan. And finally, we have Dr. Mubarak Naqvi, who will address the frequently asked questions for fasting in Ramadan, as well as touch upon COVID vaccination during fasting. We will then open up for a Q&A. We will target the discussion for about 90 to 120 minutes maximum. So without further ado, we shall begin with the first presenter, who will be Dr. Raza Zadi from the UK. And again, he will be providing the overview of diabetes and risk stratification. Dr. Raza Zadi is a consultant endocrinologist at Liverpool University Hospital's NHS Foundation Trust in Liverpool, UK since 2014. He is the head of Young Adult and Transition Diabetes Service. He serves as a lead for Transition Diabetes Service in Northwest England. His interests includes young adult and transition diabetes care, type 1 diabetes, and technology use in diabetes care. Please welcome Dr. Raza Zadi.
Thank you very much. It's an absolute pleasure to be invited and join this wonderful panel. At the outset, can I just mention I'm not an expert in diabetes. I don't live with diabetes. So in my opinion, the person who lives with diabetes is the expert. I'm just a specialist who studied a lot of diabetes and work in the field. I'm going to share my screen very quickly. Right, so I've been tasked with giving a very quick overview of diabetes. People have spent a lifetime studying this, so I've been given 5 minutes to cover this. So I'm going to be very, very quick. It's going to be a very basic overview, and apologies if it's a bit too basic, but I'm trying to address everyone. So we know the challenges of diabetes. It's a global phenomenon. And there are many forms of diabetes. There's type 1 diabetes and type 2 diabetes being the most common and popular ones. 90% of the global population has type 2 diabetes, whereas about 5 to 10% have type 1 diabetes. There are other forms of diabetes, gestational diabetes, maturity onset diabetes of the young, which is a very rare mutational genetic condition, type 3C diabetes that you can get after pancreatitis or pancreatic operation, new onset diabetes after transplantation, or cystic fibrosis related diabetes. These are very rare forms. So I'm going to concentrate for the next 5-6 minutes on the type 1 and type 2 variety. Now, whichever way you look at, diabetes as in general is a problem between the balance of glucose and insulin. And whichever form of diabetes we look at. So in individuals who do not have diabetes, the pancreas releases a hormone called insulin, which goes on to the cells and brings in the glucose from the bloodstream into the cells. This does not happen with people with type 1 diabetes, where the release of insulin from the pancreas is not there, and because of the pancreatic beta cells being damaged. And therefore, all the glucose remains in the blood and does not enter the cells. In type 2 diabetes, the insulin release is initially quite high. You get a stage of hyperinsulinemia. But the major problem in type 2 diabetes is something called insulin resistance, where the insulin that is released from the pancreas cannot work on the cells because of the receptors having a lot of resistance to the insulin. Now, simplistically, the diagnosis is very commonly made by a simple blood test called the hemoglobin A1C, which above 6.5% or 48 millimoles per mole, whichever country you live in, the variation happens with the measurement. Now, there are a couple of misconceptions that we need to clear up before I go on. The first being type 2 diabetes does not ever turn into type 1 diabetes. Type 1 diabetes is caused by autoantibodies. It's an autoimmune process where little molecules in the blood are damaging the pancreas. Naturally, type 2 diabetes progresses to a stage where the pancreas does not produce enough insulin, and that happens much later on, where an individual may need insulin. But that does not mean type 2 diabetes has turned into type 1 diabetes. The other misconception is type 1 diabetes is a condition of children and young people only. We know that about 30% of newly diagnosed people with type 1 diabetes are diagnosed after the age of 30. So it's very well an adult condition as well. Now, there are complications, and these are the things that we worry about with anyone with diabetes. And the complications acutely or in the short term with type 1 diabetes is low blood glucose levels or severe hypoglycemia or a condition called diabetic ketoacidosis. And these two are medical emergencies, which may require hospital admission. In type 2 diabetes, similar acute complications can occur, a condition very commonly known as HONC, or hyperosmolar non-ketotic coma, or which has been changed into a new acronym called HHS, or hyperosmolar hyperglycemic state. People with type 2 diabetes, if they're on certain medications, can have severe hypoglycemia as well. DKA, or what is called as euglycemic ketoacidosis, where the ketones are very high, the glucose levels being normal. In the long term, after many years of poor glycemic control or suboptimal glycemic control, you get what is called as a microvascular or the macrovascular complications, where blood vessels start damaging because of the high blood sugars. In the small blood vessels, this starts with the kidneys, the eyes, and the nerves. And in the long run, the worry always is large vessel problems, which lead to strokes, myocardial infarctions, heart failure, or peripheral vascular disease. Now, in the management side of things, for type 1 diabetes specifically, in the last 20 years, there's been a revolution in two areas. One, newer insulins, and the pharmacokinetics of these insulins is much better than what it was 20 years ago. The other revolution has been in technology. So that is through very advanced continuous glucose monitoring and flash glucose monitoring. Newer insulin injections, insulin pumps, and what is now known as something called hybrid closed loop, where insulin pumps and continuous glucose monitoring are connected and form a sort of an artificial pancreas. Also, it's important to monitor throughout the management an individual's lipid profile, blood pressure, kidney function, and other autoimmune conditions. In type 2 diabetes, again, there's been a revolution of two kinds as well, just like type 1 diabetes. The revolution in type 2 diabetes has been newer drugs and better management or better prevention of complications. So whilst managing type 2 diabetes, attention is given to diet and lifestyle management, monitoring metabolic complications, or blood pressure, kidney function, weight management. And obviously, when I started my training, there were 3 classes of diabetes drugs. And now you can see from the list, there are multiple drugs to choose from. Now, I'm going to quickly go through the risk assessment, which is a very important factor in assessing whether someone with diabetes can fast or not. A couple of things to say. The first thing being, everyone asks for evidence around management nowadays. The evidence for risk assessment is through very big epidemiological observational data. There are no randomized controlled trials, but this is probably the best we can get at this stage. And it's important to do a risk assessment very early on. I'd probably say ideally about 2 to 3 months before Ramadan, to highlight the factors that can affect an individual with diabetes during the fast, and whether you make a decision whether they're suitable to fast in the first place. So when we look at factors, we look at some Ramadan specific factors. We look at the length of fasting. We look at the season of the fasting, the geographical location of the person, social changes, and obviously past experience. Some people have had quite scary experiences in the past, and that really contributes to the future plans of fasting. I'm going to, obviously, I forgot to mention that these are the IDF diabetes and Ramadan 2021 guidelines. In the past, there have been quite a few guidelines which were a bit too restrictive. The latest guidelines, which I would highly recommend if someone's involved in diabetes care or someone lives with diabetes, to go through these. These are very elaborate but very simple to read guidelines which have been developed. So going back to the factors that may affect, there are Ramadan-related factors, and then there are diabetes-related factors. The type of diabetes influences the decision-making, duration of the diabetes. The longer you have, the longer the chance of possibly living with a complication. What kind of medications a person is on, what their previous control has been, whether they have hypoglycemic awareness. A lot of people with type 1 diabetes specifically have lost their awareness of hypoglycemia, which is quite a dangerous condition, and whether there is access to care locally. And then finally, there are individual-based factors. Obviously, you look at the age of the person, the occupation, the gender, pregnancy, meal patterns, motivational, and as I said, personal preferences. At the end of the day, I think what we need to highlight is the fact that we cannot stop someone from fasting. It's an individual choice, but it's our duty as healthcare professionals to make it as safe as possible for them. So the IDF has come out with a risk assessment tool. Before I mention the risk assessment tool, the 4 areas that we worry about with someone with diabetes, irrespective of what kind of diabetes or what management therapy they're on, there are 4 things: diabetic ketoacidosis, low blood sugars or hypoglycemia, high blood sugars, and dehydration and thrombosis. These are the 4 major risks associated with people with diabetes whilst fasting. And it's, again, the job of the individual, along with their healthcare professionals, to make sure that these do not happen, or the risk of this is minimized as much as possible. So the risk tool has been developed by the IDF Diabetes and Ramadan Guideline Group. And it looks through all the factors that I have just mentioned and gives a scoring system. At the end, you come up with a red, amber, green scoring system, where a score of 0 to 3 means you're low risk, a score of 3.5 to 6 means you're moderate risk, and a score of more than 6 means you're very high risk. So what do these risks mean? In the lower risk, obviously, the fasting is safe. In the moderate risk, there is a risk involved, and it's down to the individual and the healthcare professionals to discuss their plans as early as possible, make changes, and ensure that at the start of Ramadan, the individual would be safe to fast. The high risk, the advice is against fasting. Now, this is purely from a healthcare professional advice point of view. And I'm sure we'll touch later on in the discussion about the religious edicts around this, but this is a scoring system for healthcare professionals. So with that, I will end my short presentation, and I'll stop sharing my screen as well. Thank you very much.
Thank you, Dr. Reza Ziyati. Thank you. I would like to welcome Dr. Ishaq Aristo to address physiology of fasting and feasting, and also fasting in pregnancy. Dr. Ishaq Aristo specializes in internal medicine and endocrinology and metabolism. He is the ex-section chief of endocrinology of St. Luke's University Health Network in Pennsylvania, USA. He has over 46 years of diverse experience. He is affiliated with many hospitals, including Lehigh Valley Hospital, Muhlenberg, St. Luke's Hospitals in Pennsylvania. Dr. Aristo is an associate professor involved in teaching first and second year medical students and residents at Temple University, Pennsylvania, USA. Please welcome.
I don't have any slides. Bismillah ar-Rahman ar-Rahim. Whereas the previous speaker had taught us about diabetes, which is cellular starvation. When the sugar doesn't go into the cell, it's called cellular starvation. Whereas I'm going to discuss nutrient starvation and what happens during that process. Fasting has been practiced by humanity since ancient times. The unique feature of fasting in Islam is that it's a 30-day fast during the month of Ramadan and is obligatory to the Muslim population. And it starts from dawn to dusk, both for food and water. Most of the research on fasting that has been done on people who have been supplied water. So that is a unique feature of Islamic fasting. It should be borne in mind that Ramadan fast is an intermittent fast from sahur to iftar. Breaking the fast is done at sunset with 2 or 3 dates generally. and continuous fasting is not allowed. In fact, Prophet Muhammad said, devote yourself to the deeds that you can perform. So that is a very practical advice. And it's generally not, it is disliked to fast on Friday alone. You have to fast for 2 days, but you cannot fast consecutively without eating at all. Now, when we fast, during the fasting, a certain adaptive process is going to take place in the body. And that is a very ancient, evolved process because the brain and the body parts need sugar for its functioning. During the first part of fasting, two vital events occur. There is a slight drop in the blood sugar, that's the glucose in the blood, and with the drop, there is a slight drop in insulin levels. After about approximately 12 hours, the storage of the glucose in form of glycogen in the liver is slowly being depleted away. And the body needs sugar to continue functioning, and therefore it uses other sources of nutrients that can be supplied, and that is fat. Fat is 1 gram of fat can provide 9 calories, whereas 1 gram of protein supplies 4 calories, 1 gram of carbohydrate supplies 4 calories. So the body wants to conserve protein because protein is necessary for our muscles to breathe, to move around in the fight or flight mechanisms. So it first uses fat for its production. So as the insulin levels drop in the bloodstream, free fatty acids and glycerol is transferred from the reserves of the fat into the bloodstream. And then it goes to the liver, and there the liver produces substances called ketone bodies. Now, ketone bodies are very important because they can be, as we will see, there are 3 different varieties of ketone bodies. So in fasting, we have a condition called ketosis, whereas in diabetes, we have an extreme condition called diabetic ketoacidosis. Ketoacidosis is a life-threatening emergency. Ketosis is an adaptive phenomenon. So it has been shown that in healthy people and people who are overweight, there are remarkable benefits of intermittent fasting. One important point should be made is research has been done where water has not been withheld, and therefore we have not done a lot of research, and then young people looking into this subject may be able to explore that possibility, what happens when water is restricted in intermittent fasting. And the other thing that has not been done is the sleep variation that occurs during the month of Ramzan. Those patterns might need to be studied a little bit further down the road. It is generally discouraged for the elderly and growing children to fast, and it is prohibited for menstruating women to fast. Indeed, in these circumstances, fasting may prove actually detrimental to their health. Humanity over the past have gone through different phases of lifestyle. In the era of hunter-gatherer was marked by fasting and feasting depending upon the availability of food and game. Slowly, population settled into the agrarian groups and the cultivation of grain started. And more recent impact of changes in the lifestyle has been studied in populations like the Native Americans in Arizona called the Pima Indians in the Southwest. They have used to live a lifestyle of subsistence, agriculture, foraging, and hunting. But when they were moved into the reservations, they hardly had any diabetes, say in the early when they were living their lifestyle of subsistence farming and foraging. But now the incidence, 1 in 3 Pima Indians have become diabetic. The incidence of diabetes, obesity, and alcoholism has exponentially increased because now they have a steady supply of meat and potatoes and alcohol. So intermittent fasting has great adaptive advantages to the Pima Indians, but when the food sources became very steady, most wheat starches, obesity, hypertension, and diabetes became a manifest problem. In our modern times, obesity, diabetes, and hypertension are becoming more and more, particularly in the Muslim population in the Middle East and the Far East and in South Asia. So we must take lessons from the Pima Indians to see how we can prevent the onslaught of type 2 diabetes, obesity, and hypertension, and its consequence, coronary artery disease and strokes, from getting out of hand. It's going to be a major global population problem. The key molecule when we fast in the adaptive physiology of glucose and lipid metabolism is a molecule called beta hydroxybutyrate. That is a part of the ketone bodies that are generated, as I told you, when fats and free fatty acids and glycerol is liberated with the fall of insulin when we are fasting. So this molecule behaves not only like a fuel substrate for the generation of ATP, which is the energy molecule that the body produces called adenosine triphosphate, but it also behaves like a signaling molecule, which has an impact on lipolysis, metabolic rate, energy expenditure, insulin resistance, autophagy, and feeding behavior. So this is a very important thing. And I don't know how our prophet was able to find out that this molecule has such a profound effect, and he introduced fasting in the month of Ramadan. Although the fasting tradition has been going on for a long time, this method of fasting is a fascinating idea that has been a gift for the 1,442 years that we are benefiting from. The key changes in the different organ systems, I will quickly go through because of the time constraints. Let's go to the brain. When you fast, the brain enhances its plasticity. Plasticity is a new word that we are using for the brain's adaptive capacity. It increases neurotrophic factors. It increases stress resistance, neurogenesis, mitochondrial biogenesis, and reduced oxidative state, and it reduces inflammation. So you can imagine how beneficial fasting could be. I'm talking about the intermittent fasting, and particularly the fasting in Ramadan. It also changes the neurotrophic factor production, synaptic plasticity, and resistance to injury and disease. Now let us look at the heart. What happens to the heart? It increases the parasympathetic tone, reduces resting heart rate, increases rate variability, reduces blood pressure, and increases stress resistance. So that is another aspect of the heart. And in the blood, what does it do to the blood? It decreases insulin. When you fast, your insulin level goes down, as I told you, and that causes the ketogenesis. It alters HGF, or human growth factor 1, and leptin. Leptin is a fat hormone. Just like insulin comes from the pancreas, leptin comes from the fat tissue, and is becoming a very important hormone for us to understand. It increases ketone bodies, as I told you, as acetoacetate, beta hydroxybutyrate, and acetone. It changes adiponectin and ghrelin. These are two new hormones. It reduces glucose, reduces insulin, and reduces leptin levels. It reduces inflammatory cytokines and reduces markers of oxidative stress. So that is the effect on the blood. Let's look at the effect on the liver. It increases insulin sensitivity. It produces glycogenolysis. It decreases IGF-1, reduces lipid accumulation, glycogen depletion, and ketone body production. And in the intestines, what does it do in the gut? It reduces energy uptake, reduces inflammation, and it reduces cell proliferation and enhanced mortality. The cell proliferation is a very important factor in the evolution of diseases like cancer and new growths. And finally, in the adipose tissue, what does it do in the adipose tissue? It causes lipolysis, ketogenesis reduces leptin, increases adiponectin, and reduces inflammation. And let's look at the muscles. It increases insulin sensitivity. As you know, all type 2 diabetics, as our first speaker told us, is due to insulin resistance. And therefore, it helps in that manner, enhances anabolism, and increases stress resistance, reduces body temperature, enhanced efficiency and endurance capacity. Finally, in regards to the behavior, fasting in Ramzan requires some changes in our behavior, like looking up at the sky for the phases of the moon, observing the dawn and the dusk of each day, modifying our eating, drinking, and sleeping habits, controlling our speech, our emotions, and our desires. That's paying more keen attention to our prayers and the study of Quran. During fasting, there's an increase in productivity and less anxiety overall. Intermittent fasting has shown enhancement of brain functions, increased performance on motor and sensory tests, improved learning and memory functions, and substance like brain-derived neurotrophic factors, which has a role in energy uptake and expenditure. As a physician, one can make a diagnosis and prognosis about a person's health and disease and make recommendations. But this does not supersede our concept of patient autonomy and Allah's hukum. In conclusion, I would say that understanding the changes in the metabolic and psychological benefits of fasting only enhances the faith and the profound value of these blessings that are given to the believing Muslims. I will just give you a few more minutes to talk about pregnancy. Now I'm going to use some technical words here. Pregnancy is a state of accelerated catabolism and facilitated anabolism. What do I mean by that? When a pregnant woman starves or doesn't eat, she goes into a catabolic phase. That means it requires more and more nutrition because the fetus and the mother is both consuming calories. But when a pregnant woman eats, she becomes anabolic because there is placental lactogen and other hormones that make her store those calories and supply it to the fetus. So fasting in a pregnant woman will accelerate the catabolism, and when she eats, will accelerate anabolism. She will generate ketone bodies at a quick pace when she is fasting. And the effect of ketone bodies in the developing fetus is just being studied now. These quotations that I have taken is from Dr. Norbert Frankl in his lectures on diabetes called the Banting Lecture. The fetus is going through 3 phases: the first trimester, the second trimester, and the third trimester. In the first trimester, organ differentiation and genetic evolution of the structures are being made. In the second trimester, organ formation is occurring. And in the third trimester, you have maturity of the surfactant membrane of the lungs, and the liver and other organs are maturing. So in each phase of during pregnancy, different aspects of metabolic impact will occur when a woman is fasting or when she's eating. And there are conditions that can be acutely felt only by pregnant women who are diabetic, either as type 1 diabetic before pregnancy, or type 2 diabetes, or it could be gestational diabetes, which is uniquely present during pregnancy and clears up after the delivery of the baby. So I'll stop here now, and we may be able to address the various aspects of different fasts that have been evolved, even in Islam, like the Ashura fast, the fast of King David, of Prophet Dawood alayhi salam and other types of fast. We can also discuss other aspects of starvation, fasting, and what happens when we eat. I'll stop here. Thank you so much.
Thank you, Dr. Arastu, for the beautiful elaboration on the physiology of diabetes, and as well as touching upon pregnant patients and fasting. It was extremely informative, and the connection to past to present was excellent. I'd like to introduce the next speaker, Dr. Wahida Karmali, to address the risk factors such as hyperlipidemia, hypertension, obesity, and elaborate on diet and exercise while fasting. Dr. Wahida Karmali is the Special Research Scientist at Columbia University, New York, USA. She is the ex-director of the American Diabetes Association. She is also on the board of directors for the Accreditation Council for Clinical Lipidology and member. She is on the expert committee on disorders of lipid metabolism for the Academy of Nutrition and Dietetics. She is also the associate editor for the Journal of Clinical Lipidology. Please warmly welcome Dr. Wahida Karmali.
Assalamu alaikum. Thank you so much for your kind introduction, Dr. Almechi. During my short presentation, I believe I've given 7 minutes to speak. Hopefully we can carry on our discussion during the discussion hour. So in my talk, I'm going to talk and discuss diet and physical activity guidelines while managing diabetes as well as comorbidities. So for Ramadan, we need to think of resetting, which means we have to plan ahead of how we are going to manage the diabetes. So Ramadan itself represents a challenge to both patients with diabetes as well as healthcare professionals, considering the fast can last somewhere between 12 hours and 21 hours, depending on the country you're living in. And studies have demonstrated a clear benefit of Ramadan-focused education in terms of glycemic control, weight management, and a reduced risk of hypoglycemic episodes. In fact, the studies showed that you can reduce hypoglycemic episodes by 50%. So what's needed is an assessment of patients' nutrition at least 2 to 3 months before Ramadan. This gives an opportunity for healthcare professionals to advise patients with diabetes on how to eat healthfully. So we can provide a nutrition plan with patient participation, looking at any medication adjustments. So we'll be able to improve glycemic control with macronutrient and calorie distribution as well, to optimize nutrient needs and manage comorbidities, if any, during Ramadan, and also optimize nutrients to meet maternal and fetal needs in pregnancy. We need to know there's no one-size-fits-all approach to nutrition, health, and personal changes. So we need to personalize our plates to optimize glycemic response and quality of life. We know there is a direct relationship between our eating patterns, physical activity, and health. And nutrition is a key player when it comes to our physical, mental, and social well-being. We need to address comorbidities like hypertension, because 60% of the patients with diabetes are hypertensive and at least have one or more lipid disorders. And in a lot of cases of type 2 diabetes, there is an issue with weight management. And a lot of patients we are seeing now have non-alcoholic fatty liver disease. There are different eating patterns that have been studied. So there's evidence for the DASH eating plan. DASH, which the acronym stands for Dietary Approaches to Stop Hypertension. The Mediterranean diet has been also very well studied, and we have some data on low carbohydrate diets. So if you look at the DASH diet, which was originally planned to look at effects on blood pressure, The DASH itself can lower systolic blood pressure by 8 to 14 millimeters mercury. And if you add on a low sodium to it, it can further reduce 2 to 8 millimeters mercury. And physical activity can also give a reduction of 4 to 9 millimeters mercury. And it's also, the DASH diet has also been looked at in patients with diabetes and has been found to be very effective. And so has been the Mediterranean diet. There's some differences between the two diets. The Mediterranean has whole grains, lots of vegetables, some fruits, and fish, more seafood compared to the DASH diet, because the DASH diet also includes lean meats, chicken without skin, and small portions of red meats. So management of risk factors such as hypertension, dyslipidemia, overweight, obesity, hyperglycemia is crucial and should be addressed during Ramadan. So the desirable goal for triglycerides is less than 150 milligrams per deciliter. Now, when it comes to pregnant women who are fasting and who have diabetes, you will see that triglycerides increase throughout pregnancy. And it's seen in all gestational stages in patients with diabetes. So the triglyceride levels have to be monitored very carefully. Triglycerides under 150 is certainly a risk factor for, under 500, between 150 and 500 is a risk factor for cardiovascular disease. And if triglycerides are higher than 500 milligrams per deciliter, they can quickly rise to 1,000, which is a risk factor for pancreatitis, which can be a high risk for women who are fasting. And the HDL levels have, the desirable levels should be over 40 milligrams per deciliter in men and over 50 milligrams per deciliter in women. The LDL goals for patients with diabetes has to be less than 70 milligrams per deciliter or even lower, because 65% of the patients with diabetes die as a result of a cardiovascular event. So LDL is a very potent risk factor for heart disease. Normal blood pressure is defined as a systolic pressure of less than 120 millimeters mercury and a diastolic of less than 80 millimeters mercury. The waist circumference is also very important. We have waist circumference for different ethnicities. What's really important is to look at Asian Americans, South Asian Americans, as well as other Asian Americans where our cut points are lower than for Caucasians and for other ethnicities. So medical nutrition therapy should be tailored to fit each one's caloric needs, the pharmacologic treatment, as well as medical conditions and medical outcomes. So the diet during Ramadan fasting, the guidelines state that patients should consume nutrient-dense balanced meals and hydrate themselves from iftar to suhoor, which is from sunset to dawn. And when you talk about nutrient-dense balanced meals, it means foods that are not highly processed, which have all the micronutrients, the vitamins, the minerals, and they have fiber in them. And they're not just simple carbohydrates like sugars and syrups or honey, which all have an effect on creating high levels of blood glucose. Patients should also distribute carbohydrate intake among meals to minimize the postprandial hyperglycemia, which is the blood glucose rise after a meal. And comorbidities, as I said earlier, have to be treated with patient participation. So for the diet for diabetes during Ramadan, we don't have controlled clinical studies to show what's really optimum, but we have some consensus on how to eat during Ramadan. So the guidelines include divide the daily calories between suhoor 30 to 40% of the calories, and iftar a little bit higher, 40 to 50%, and include 1 to 2 snacks if necessary. So ensure the meals are well balanced. It should have lean protein. It can be from fish or chicken or beans, lentils. And the fat has to be high in monounsaturated and polyunsaturated, which means not including butter or ghee or coconut oil, but rather including olive oil, canola oil, soybean oil, safflower oil, sunflower oil, which are high either in mono and polyunsaturated. Nuts are also a very good source of fat, and these are all unsaturated fatty acids in the nuts. The diet should be low in cholesterol. You may be hearing that don't bother about cholesterol intake, but that's not true. We have studies to show that cholesterol intake is really important, especially when you have diabetes, and because there is a dietary cholesterol raises the LDL cholesterol and increases the risk for heart disease. Although it's not as potent as having saturated fat in the diet. So the trans fat in some countries are still used, and they should be minimized or not used at all. And particularly foods, during iftar, people typically serve as an appetizer fried foods, and these should be also limited because the calorie intake will increase due to the calories in the fat. Avoid sweet desserts and anything with syrups, even agave syrup. People have misconceptions that because they are natural, they're okay, but they're not. They all behave like sugar in the body. So it's really important to avoid even fruit juices, because if you rather eat a fruit which has a fiber and other nutrients rather than just drinking fruit juice, which will raise your blood sugar. It's good when you have hypoglycemic episode where you need to push your blood sugar up quickly, where you need to have at least 15 to 20 grams of simple sugars. It could be glucose, and if you don't have that handy, you can have a fruit juice or honey if you have that in your home. The amount of oil should be controlled. It's not, though the Mediterranean diet says use olive oil, it just doesn't mean pouring olive oil on everything you eat. Olive oil also is caloric. 1 gram of olive oil will give you 9 calories like any other fat. So hydration is really important between sunset and sunrise. So it's important to drink water. And any other unsweetened beverage, like if you're going to make like a yogurt drink without any added sugar to it, that would be a nice drink to have, which will help you to be hydrated. Avoid caffeinated and sweetened drinks, and avoid salty foods. So changes in physical activity and sleeping patterns can affect metabolism and may contribute to weight gain. So it's really very important that you spend less time watching television or just sitting around. So with physical activities, most adults with type 1 and type 2 diabetes should engage in 120 minutes or more of moderate to vigorous intensity aerobic activity per week. Not very vigorous though. It could be spread over at least 3 days per week with no more than 2 consecutive days without activity. We don't want people to do rigorous exercise during fasting because of the increased risk of hypoglycemia and dehydration. But to do light to moderate exercise during Ramadan is recommended. So what are my choices during Ramadan? We have lots of foods to choose from to make the food interesting. If you're going to somebody's house for iftar, it's really important to even look at what the person has served before you start putting foods on your plate, because you may not enjoy the foods that are at the beginning of the table, but probably you would enjoy something at the end of the table which has more vegetables in it. So it's really important to be mindful of what you eat during Ramadan. There are some of these resources. The DAR has been updated 2021, so you can look at the most recent DAR guidelines. So we have to be mindful that millions around the world face hunger, including millions of children. So while this mother is taking a cart full of food to the food pantries, her child wants to feed all the hungry children in the world. And as Imam Ali said, we are all equals in humanity. So it doesn't matter who you are or where we live, people have to be fed. And Ramadan makes us realize what hunger is and even thirst, because there are millions of people who don't get potable water to drink. So with this, I conclude, and I'd like to wish everyone Ramadan Kareem.
Thank you, Dr. Wahida Karmali. Ramadan Kareem for you too. I would like to invite Dr. Ali Asbar to discuss the management for type 1 and type 2 diabetes while fasting during Ramadan. Dr. Ali Asbar is practicing as a consultant endocrinologist and diabetologist at Liaquat National Hospital and Medical College in Karachi in Pakistan. He also practices at Medicare Cardiac and General Hospital and Fatimiyya Hospital in Karachi. Please welcome Dr. Ali Asbar.
Bismillahir Rahmanir Rahim. Assalamu alaikum, everybody. Already fantastic talks, and I think great work by IMI to hold this webinar for people as well as for the general practitioners and specialists. So just let me share my screen. Okay, so can you see my screen now?
Yes.
Yes.
Okay. Okay. So my screen is visible to you all?
Yes.
Okay, so let's begin. So my job is treatment of diabetes in Ramadan. Now, before I begin, already fantastic talks on risk stratification, diet and exercise. Look at this, Pakistan, from where I come, is 4th in the world in number of people with diabetes. And I'm sure India is ahead of us, US is ahead of us. Now, these guidelines have been prepared from the ITF-DAR guidelines 2021. Now, let's talk about diabetes type 1. And this is where I believe that risk stratification has taken place, and we have decided that type 1 diabetes patient is going to fast, how to adjust the medications. Now, earlier it was thought that it's very difficult for the type 1 diabetes patient to fast, but various studies have now demonstrated that many type 1 diabetics can actually go on and fast in Ramadan. But this allowance cannot be generalized across to all individuals. The important thing is the pre-Ramzan education, counseling, dose adjustments, frequent glucose testing during Ramadan, and CGM and FGM much superior to SMPG. So once we have decided that the type 1 diabetic patient is going to fast, how to adjust the dose? So let's talk about the basal insulin. So if type 1 diabetes has good glycemic control, HbA1c less than 7.5%, reduce the dose by 20 to 30%, the basal insulin. Take it at iftar or whatever time the patient is taking. If the type 1 diabetic has poor glycemic control, which is more than 7.5%, then there might not be any need to reduce the dose. Just continue with the same dose of basal insulin. Now, before I proceed any further, these are just general guidelines. Your dosage adjustment, if you are the patient or the family, is going to be according to the general practitioner or diabetes specialist. So prandial insulin, which is the bolus insulin, again, if the patient is on fixed doses, then you don't need to make any change at iftar. But the seher dose goes down by 20 to 30%. But this again can be different. If the iftar is a heavy iftar, you can actually increase the iftar bolus or prandial dose. And if the seher is a light one, you can maybe go even lower then 20 to 30%. You can go up to 50% reducing the seher dose if the seher is light. So it's very important that you individualize your patient. Coming up to the diabetes type 2 patient, we've got lots and lots of medications. As Dr. Raza said, I mean, 15 years ago, we probably didn't have many medications, but now there are lots and lots of medications. So starting from metformin dosing during Ramadan, if metformin is once daily, it's pretty simple. You take it at iftar. And it's very simple. If any medication is once daily, it has to be taken at iftar. Twice daily dosing, you don't need to adjust metformin. You take it at seher and at iftar. Usually the larger dose goes at iftar. If the dose is 3 times daily, then you omit the lunch dose, or you can add the lunch dose to the dinner dose, provided you do not exceed 1000 milligrams of metformin at iftar. And if it's a prolonged release metformin, then you don't need any dose adjustment. And if it's once daily, it goes as iftar. So it's very important. If you are on any medication that is once daily, it goes as iftar. Acarbose, again, so again, acarbose, you don't need any dose adjustment for acarbose. If you're taking acarbose once daily, again, you take it at iftar, but you can even take it at seher, and there is no need to reduce the dose. Pioglitazone, it's not used that often these days world over, but again, the risk of hypoglycemia is very low, and you don't need any dose adjustment with pioglitazone. Again, I would say that if you're using it once daily, it's always better to use at iftar timings. The short-acting insulin secretagogues. So again, the short-acting insulin secretagogues like repaglanite, they're very short-acting. You can continue the dose at seher and iftar, and if the seher is light, you can reduce the seher dose. If the iftar is heavy, then you can maybe increase the iftar dose of insulin secretagogues. The GLP-1 analogs, whether it's liraglutide or dulaglutide, which are available in this part of the world, we don't have lixisenatide and exenatide here. Well, if the dose is well titrated, then again, you don't need any dose adjustment for GLP-1 analogs in Ramadan. The DPP-4 inhibitors, beautiful medications, I mean, hardly any side effects. Again, you do not require any treatment modification. If it's a twice daily dose, just carry on with that at seher and iftar. If it's a once daily dose, you can just switch it at iftar. Coming up to the sulfonylureas, that can cause hypoglycemia. So if it's once daily sulfonylurea, you take it at iftar. And if it's twice daily sulfonylurea, then the night dose becomes the iftar dose and you carry on with the same dose. The morning dose goes at seher, and what you do basically to the morning dose, there's some problem with my, okay. So yes, the night dose goes at iftar and the morning dose comes at seher and becomes half. Do not use older sulfonylureas like glibenclamide. You can use gliclazide and glimepiride instead. Again, SGLT2 inhibitors have low risk of hypoglycemia. You don't need any dose adjustments. Coming up to the long and short-acting insulin dosing during Ramadan. So again, if you're using short-acting insulin, very easy. You carry on the same dose at iftar, omit the lunch dose, reduce the seher dose by 25 to 50%. I'll skip a few things because we can always discuss during the Q&A. It's very important if you're using basal insulin, then if the blood sugar is less than 70, reduce the insulin by 4 units. If the blood sugar, pre-fasting blood sugar is less than 90, reduce by 2 units. The ideal blood sugar is 90 to 126, where you do not need any change. If it's more than 126, increase by 2 units. More than 200, increase by 4 units. But this is just a general guidelines. I mean, if your patient is on high dose of insulin, 2 and 4 units probably might not do anything. So these are just general guidelines to explain what the target levels are. Actually, you are, as a physician, we are in the better capacity to adjust the dose and teach our patients how to do it. Now, the premixed insulin dosing during Ramadan. Now, premixed insulin is usually taken twice daily, but if we are taking it once daily, then the dose goes at iftar. If we are taking twice daily, then the iftar, the dinner dose remains at iftar, remains the same dose. The morning dose comes at seher, gets reduced to 20 to 50%. And if we are taking 3 times, of course, we omit the afternoon dose and adjust the nighttime, the dinner, and the morning doses accordingly. Again, these are just general guidelines. If the seher is less, you can go down to up to 50%. And if the iftar is heavy, maybe the iftar dose can go up a little bit. And this is something that we have to do in this part of the world where iftars, despite all the education, is sometimes pretty heavy. The dose adjustment remains the same. The insulin pump doses, again, the basal rate in the last 3 to 4 hours of fasting gets reduced by 20 to 40%. And post iftar in the next couple of hours, maybe the basal rate goes up by 10 to 20%. The bolus rate remains the same, and you can always actually calculate the carbs and take it. It's very important to know when to break the fast, as we just saw a fantastic quote. It's easy to know how to fast, but it's sometimes difficult to know when to break the fast. So all individuals should break their fast if blood glucose is less than 70 milligrams per deciliter or more than 300 milligrams per deciliter, or if there are symptoms of hypoglycemia or acute illness, or if the patient is not feeling too well. Thank you very much, and I'm sure I've not exceeded the given 7 minutes. Thank you very much once again for inviting me.
Thank you, Dr. Ali Asghar, for articulating the management on type 1 and type 2 diabetes and reviewing in detail each medication category. I'd like to now invite our final speaker, Dr. Mubarak Naqvi, who will be addressing frequently asked questions pertaining to fasting with diabetes during Ramadan. He will also be addressing questions regarding COVID vaccination during fasting and religious ethics on diabetes in Ramadan. Dr. Mubarak Naqvi is the IMI Global President and a graduate of Aligarh Muslim University, India. Dr. Naqvi is the medical head of insulin-based therapies, China, and emerging markets at Sanofi. He has worked at leadership positions in clinical research and medical affairs in the United States, Europe, and India. Now let's please welcome Dr. Mubarak Naqvi.
Assalamu alaikum, everybody. Can you hear me?
Yes.
Yes.
Excellent. Let me quickly project my screen. All right, so we will have an extensive Q&A section, but there are a couple of things that the panelists thought should be addressed a little bit upfront because that would require some references and all. So I decided to take up some of the commonly asked questions or frequently asked questions. The first and foremost, what we as physicians get asked a lot is that what is the learned advice of our Islamic scholars for diabetes patients during Ramadan? What can be done, what cannot be done, etc. So the first question is, can people with diabetes fast? Yes, of course they can, and in some cases, no, they cannot. Depending upon the risk categories that have been described earlier, I'll quickly refer to it again in the next slide. Can they take oral medications? Yes, oral medications can be taken, but they cannot be taken in the state of fasting. They can be taken at iftar onwards until suhoor, not in the state of fasting. Can they inject insulins in the state of fasting? I will show you the religious opinion of various authorities and maraji on this in a few minutes. The general consensus is that yes, injection of insulin is permitted even during this state of fasting. Of course, it is permitted after iftar and until before suhoor, but it is also permitted in the state of fasting. And can they perform blood tests in the state of fasting? The answer again is yes. By most Islamic scholars, finger prick test to test your blood sugars, as well as blood drawn from a vein, both are permitted. And for the regular tests, we need a very small quantity. The condition is that the quantity should not be so much to affect the general health of the patient. Now, you have seen this before. IDF DAR guidelines have given these details about different risk factors. And once you calculate the risk, and if the person is at high risk, should not fast, moderate risk, should be advised by the clinicians not to fast. But in our experience, we have seen that many such patients would still like to fast, and that is the time when physicians should act in the best interest of the patient's safety. And while respecting the personal wish of the patient, try to reduce the risk as much as possible. And the low risk patients can fast, but again, of course, under medical supervision. Now, where does fasting come in Holy Quran? There are, of course, many references. The one that I wanted to highlight before I come to the religious edicts is Surah Al-Baqarah, these 3 verses. And the highlighted section, as you can see, Allah tells us that the one who is sick or is on a journey should fast as much on the other days as he has missed during the days of illness or the journey. Because Allah intends to provide ease for you and does not intend to create hardship for you. What are the rulings of our Maraji Karam? There are 2 forms in which these rulings can be found. One is in the form of Q&A and the other in the form of ruling. So in the form of Q&A, Ayatollah Sistani was asked, what is the Islamic ruling about someone who is suffering from a disease? How should he or she go about fasting? The consensus is, of course, that if the particular disease or illness threatens the health of the person, then he or she should not fast. If fasting would worsen the poor state of health in any way and hamper the recovery from or increase his pain, then this person should not fast. He or she can commensurate it later on by fasting the same number of days. Or if till the end of the year he or she is not able to compensate, then kafara is there. In terms of ruling, the ruling is about injections and intravenous drips. Ayatollah Sistani is of the view that any kind of injection or IV drips do not invalidate a fast, even if the former is an energy injection and the latter is a glucose saline drip. And then there are rulings about drugs that are inhaled and others as well. And I've given the references for both of them. There was also a question on the chat box that we will address later, but here the question was, I'm pregnant and would like to know whether I should fast or not. Perhaps in the early stages, one can fast if the health is permitting, but at an advanced stage of pregnancy, fasting can harm the mother as well as the fetus. Therefore, it is not advised. And then if there is any concomitant illness like diabetes, of course, the whole question of risk factors and other things come into play. About intravenous injections, there are different rulings by different Maraji. The summary is that if the injection is for medical use, all the Maraji have permitted that. If the injection is for nutritional use or it is a tonic, then they have a different opinion. Some of our Maraji Karam have allowed that as well, and others are of the view that if the injection is for a nutritional or a tonic or taken as a tonic, then it will break the fast. But as far as taking insulin or getting blood test is concerned, there is a consensus amongst all Maraji that it is permitted. This is a research paper as well, not from our Maraji, but again, it has been just to highlight that these topics have been well researched and well published. This is from other schools of thoughts, the Standing Committee for Academic Research and Fatwas and Islamic Fiqh Council. There also the opinion is almost similar, and it has been published in a journal by these 2 researchers from Boston, US. What about performing blood tests? As I mentioned a little while earlier, it is permissible as per most schools of thoughts, and it is as per what is published by the Supreme Leader of Iran, Ayatollah Khamenei, that it will be makruh if the quantity of blood given is so much that it causes weakness. Otherwise, for general tests where hardly 5 ml blood is taken or 10 ml blood is taken, it is permissible. So that addresses the religious side of it, but there are many other questions as well. A couple of them I've addressed here. What should I do before Ramadan? Should I increase or reduce doses? This has been covered very nicely in the previous talk, so I'm not going to repeat that. The fundamental principle is that the patient should consult their respective physicians prior to Ramadan, along with all the basic test reports. And it is your physician who will decide if medications or doses are to be changed as per the different parameters. Typically, you should get your sugar panel done, your lipid profile, renal profile, and about 2 weeks before Ramadan, or even a couple of months before Ramadan, if you start talking to your physician, it would be a good time to review your glycemic control and advise the patient accordingly. Now, if the sugars are well controlled, then some medicines may require dose reduction, as was just covered. Whereas if not, then it may not require any dose reduction. There are some relatively newer medications that have lower hypoglycemic risk. This is not a comprehensive list, but yes, DPP-4 inhibitors are known to cause lesser hypoglycemia. Same is the case with GLP-1 agonists. And then amongst insulins, the second generation basal insulins are known to have a much flatter profile and are known to cause less hypoglycemia, whether it is glargine 300 units or, per ml or Tresiba, that is degludec. Another question could be that I'm on insulin therapy. What is the best time to inject my insulin? What are the do's and don'ts? Again, Dr. Ali Asgar has covered the detailed nuances of that. IDF-DAR guidelines that have been referred to by multiple speakers here. They give the detailed algorithm. Again, the fundamental principle is that frequent glucose testing is extremely important. Iftar should not be delayed, especially by diabetes patients. Recently, we did a particular study on one of the molecules from my company, Sanofi, which is Toujeo, in Ramadan. And what we noticed that out of many countries that were participating, the incidence of hypoglycemia was highest in Canada. And when we dived deep into the data, we saw that in Canada, the fasting duration was about 3 hours or 3.5 hours more than India or Middle East. And we also saw in the data that majority of those hypoglycemic events were happening in the last 2 hours. So the hypoglycemia in these conditions tends to happen at the very end, just before iftar. So undue delay in iftar is not to be done. And similarly, suhoor should not be missed, especially by a diabetes patient. And in case of hypoglycemia, that is where glucose goes less than 70 milligrams per deciliter, or where you get the values in millimoles, then less than 3.9, the fast should be immediately broken and a physician should be consulted if possible. The fourth question, especially amongst the clinicians, is that these whole guidelines and these discussions that we are having, are they evidence-based? Are they based on research? Or these are general opinions of people? So in the last few years, last decade or so, extensive research has been done in diabetes and Ramadan. And many of the new molecules, they are specifically generating efficacy and effectiveness data and safety data during Ramadan. What I've posted here is some of the research papers. For example, back in 2004, a large epidemiology study was done in 13 countries called EPIDR study. Similarly, there was a CREED study, which studied hypoglycemia in Ramadan. Then different molecules, including Lantus over here, Toujeo here, and then degludec, insulin degludec here, lixisenatide here. All these molecules, and liraglutide on the right side, bottom, all these molecules have done specific studies, whether an observational study or a randomized controlled study to study diabetes and Ramadan. These are two of the studies that I was part of recently. One is completed, which is on Toujeo, where we studied the safety and effectiveness of Toujeo during Ramadan. and it had extremely low incidence of hypoglycemia and improvement in A1C during the Ramadan duration. And this other study, the Ligzi-Ram study on Soliqua in Ramadan, is ongoing right now. It is distributed over 2 years, and it happened last year and will continue this year. Lastly, in terms of evidence, this has been referred to many times. This has extensive bibliography where you can find all the data that has been published in Ramadan so far. So please do go through this. Now, coming to my last slide, which is the question of COVID vaccination in Ramadan. Some fundamental things to clarify. There's a lot of confusion in different countries, especially in India. I get this question a lot, whether we should get vaccinated or not. Now, COVID vaccines are generally safe and effective. You should please follow your country's guidelines on COVID vaccination. This is the general advice from IMI. The risk-benefit profile of COVID vaccines, the experts have studied that, and they have found that while there are risks, but the benefits far outweigh the risks. Hence, it is advised for all eligible people to get vaccinated. As far as Ramadan is concerned, it is of course permissible to take the vaccine. We have seen that earlier. The same rules that apply for COVID, for insulin injection apply for this vaccine as well. However, please be mindful that after the vaccine, a lot of patients have reported malaise and slight fever, and they are down for a couple of days. In such a situation, it may not be advisable to fast for the duration of the malaise that is the post-injection flu-like symptoms. And for the vulnerable population, like very elderly patients or those with comorbidities and who are immune compromised, please consult your country's guidelines and your personal physician before you get vaccinated. So that is it from my side, and we can now move to the Q&A session. And
thank you, Dr. Mubarak Naqvi, for shedding light on the most commonly asked questions. But before we move into the question and answer session for today's program, I'd like to introduce Imamiya Medics International Global Coordinator, Ms. Shifa Abbas.
Thank you so much, Dr. Yemal, and thank you so much to our esteemed panelists and Jamana, and thank you so much for having us being able to host this really important and necessary conversation for so many of our beneficiaries and our members. I just wanted to highlight, inshallah, going forward, Dr. Wahida did such a great job of highlighting the importance of providing nutritional aid and aid in the form of water and food, especially during Ramadan. And I'd like to introduce you all to IMI's Ramadan Appeal. We are hoping to deliver food baskets to families this Ramadan. The COVID-19 has afflicted areas around the world, including India and Pakistan, in Tanzania and Burkina Faso, and across the Middle East, as well as in Europe and North America here locally. Our beneficiaries of this food basket campaign include orphans and widows, the injured and ailing, people who have lost their homes and sustenance during this terrible pandemic, also families ravaged by terror, violence, and now COVID-19. So I would encourage you to please check out the chat, visit us at www.imamiyamedics.com. You can sponsor a food basket of rice, oil, sugar, tea, and other essentials, as well as fresh fruits and vegetables, all of the essentials that are required for healthy nutrition of an entire family for only $30 US. And our goal, albeit a very lofty one, but not for the thousands of people watching today, is 25,000 baskets. So I do encourage you all, inshallah, to donate with all of your support. We will be able to reach our goal. And with that, I'll hand it back to you, and I'll drop it in the chat, inshallah. And with your support, everyone will be able to get to our goal of 25,000 baskets. Here's just a picture of some of the ongoing work that is already underway. A lot of the food baskets of the 25,000 target have already been packaged and delivered. So we're looking forward to your support, inshallah, to make this goal a reality.
Thank you, Shifa. We will now start the question and answer session. We had excellent presentations by our 5 panelists, and we are graciously thankful to them. And the first question will be asked by Jumana. Go ahead, Jumana.
So this question is to Dr. Ali Asghar. What will you recommend to patient with polycystic ovarian syndrome with insulin resistance about fasting, and they are on high dose of metformin? We can't hear you. It's on mute.
Oh, you can hear me now, Jumana? Great, thank you. So
Yes,
again,
yes.
the question is on a lady with PCOS on metformin and probably not diabetic. Now, metformin is a beautiful medication. It usually doesn't cause hypoglycemia and can be safely taken in a lady who is having PCOS. And even in diabetics, metformin can be easily taken during fast, and it does not cause hypoglycemia. And there is no dosage adjustment also that is required with metformin, whether we are talking about a lady with PCOS or somebody who has diabetes. I mean, it's pretty easy to take medication in Mahi Ramadan.
Thank you very much. The next question by Dr. Yamal, please.
So the next question is for Dr. Rahida Karim Ali. The question is seeking input on a strong statement that was heard from another practitioner about salt restriction. It was emphasized that there is no need to restrict salt and let the body do the work. What are your thoughts on that?
The recommendation for sodium intake is 2,300 milligrams per day, which is like a teaspoon, which comes from all foods. As I said, people with diabetes, about 60% of the people with diabetes are hypertensive. So lowering salt intake will have an effect in lowering blood pressure. But you can't have, and also too much salt intake will also increase your thirst. So it's really very important to make sure that you're not exceeding the limits so you get thirsty during the day as a result of consuming so much sodium. I just wanted to make a comment on the COVID, just want to have some clarity on that. So Dr. Mubarak, don't you think people should be told that they have to be properly hydrated when they take the vaccine, so that they should go for the vaccine closer to suhoor rather than later in the day?
So thank you, Dr. Karamali. That's a very good observation that yes, hydration is extremely important when you take the vaccine, because as I mentioned, the flu-like symptoms are very common after taking a vaccine, and your hydration plays a very important role. So yes, if you intend to take your vaccine and you are fasting, then it is better to go more towards suhoor, which is logistically might be a challenge. But be prepared for the possibility that you may not be able to fast for a couple of days after you take the vaccine.
Thank you.
So the next question will be for Dr. Muhammad Ishaq Arusto. The question is what you will advise to the pregnant women about fasting to reduce catabolism?
It's a tough question because I'm going to be advising both for the quiet fetus, which has no voice of her or his or its own, and the mother also. But I think if the woman is suffering from any comorbid condition, they should probably avoid fasting, including gestational diabetes. In terms of preeclampsia, hypertension, and they should also not be fasting. I think they will become much more ketotic if they fast in those conditions. Fasting preconception, if they are planning to have a baby in future, is an interesting situation, particularly with PCOS and metformin use. Fertility might actually improve because of the changes in the sex hormone binding globulins and ovulation, etc. But I think it will be very individual in terms of making a recommendation based on the individual condition of the person. So I hope I've given a reasonable answer here.
Thank you for that answer. And I'd like to have Dr. Shabi Zadi, Chancellor of Sadiq International University, pose his question. Dr. Zadi.
Thank you so much. I'm so impressed with this wonderful, I mean, every lecture was so powerful. Dr. Isakar, of course, in particular, of course, Mubarak. My question to the panelists, particularly Mubarak Naqvi, is that in the UK, there's a lot of controversy on the vaccines. I mean, for example, we took Pfizer and we're happy with it. But some of my colleagues who had AstraZeneca living in the Holland, in the Netherlands, they had problems. So there is a great deal of controversy that's going on because of what I'm sure you know, the clots and thrombosis and everything. So what is the opinion of the experts? If somebody asked me, because somebody called me day before yesterday, that, and he's a doctor, in fact, that what is your opinion? I say, I don't know, because I'm only a patient. I just went and they gave me Pfizer jab. I'm quite happy with it. In fact, I would recommend they should have it. He was a little apprehensive because one of his patients had a thrombotic phenomena. It may not be related to AstraZeneca. It could be just. So what is the advice of the expert? The second is my request. The request is that such a wonderful webinar, may I request all the panelists to please be our guests on Sadiq International Virtual University platforms. We've just completed a wonderful conference of 5 days that some of you probably attended. And we would like to invite you whenever you can for webinars. Shifa is our registrar, like she is IMI Global Coordinator. Kindly come forward and help us build up the portfolio of lectures and webinars and seminars. Thank you.
Thank you, Dr. Shabi Zadi. And I will let other experts also chime in, but first, my thoughts. So as everybody is aware that these vaccines were created in a record time. So this is unprecedented. It is not something that has ever happened before in the history of vaccines. Therefore, all the rigor and all the extensive clinical trials that used to happen, it's not happened the way as with other vaccines that we have taken in our childhood or adulthood. So some questions still remain. Now, thrombosis is one of the widely reported issues, not only with AstraZeneca vaccine, but with some others as well, but predominantly with AstraZeneca. Majority of these reports have been in extremely elderly, very elderly people, or those who have a predisposing condition, a cardiac condition, an oncology condition, etc. So the risk is definitely there. But as I mentioned in that slide, that when you look at the risk-benefit profile, so today one of my close relatives was unwell because of some other problem, not COVID, and they were staying at my place. They just went to the hospital while this meeting was on, and I got a message that in the hospital, 95% beds, and it's a large hospital with 1,200 beds, 95% of the beds are for COVID and they are all full, and the remaining beds, there's absolutely no space. So the situation is terrible. It's very serious. So the overall risk-benefit profile of the vaccine still favors the benefits rather than the risks. But yes, some unanswered questions are there. So my advice to my colleagues is that please go and get the jab.
Thank you,
And,
Dr.
and to my other requests of being our guests as speakers in the webinars in the future at your convenience.
Anytime, Shabibai, always there. Please let us know when and what we have to do.
Thank you so much. Very kind, Mubarak.
You can count me also in, Shabibhai.
Thank you. I think I wrote to you, but we're
Yes.
busy maybe next year
Yes.
whenever you have time.
I was a little bit preoccupied, but inshallah from May, it will be okay.
And everybody else, Ali Asghar and all the other panelists, please come forward. We're doing a reasonable job, but we want to augment it with your personalities and your input to build the Sadiq University to an international level. Thank you.
Inshallah.
Now, I just add in about the COVID vaccination very, very quickly, just to add a point to Dr. Naqvi's statement. It is a learning process, and we're learning every day. There are randomized control trials which have been taken, which have been in the thousands, but then what you see in the real world is also at times different. Just a quick analogy there with the risk of clots with COVID-19 vaccines is about 0.007%. When people get admitted for any reason to a hospital, they get something called Clexane or VTE or thromboprophylaxis injections. The risk of heparin-induced thrombocytopenia, which is a fairly commonly known side effect of VTE or Clexane injections, is about 10 times that. Yet we propose that. So the risk is extremely tiny, and it is there in those people who perhaps were a bit more vulnerable to clots anyways. So I think the vaccine hesitancy is probably quite high, but I think this should not be one of the reasons for that.
Can I add something here? Dr. Mubarak and Dr. Raza completely agree with both of you. I mean, in Pakistan, we are using the Chinese Sinopharm vaccine, and at the moment, we are doing very well with the vaccine. We are due to receive the AstraZeneca vaccine in coming days, 2 weeks. There are apprehensions of the general public, but I think from this platform, it's very important to tell all of our viewers that it's very important to take the vaccine rather than to take the COVID. Actually, that can be more detrimental, even in diabetes, especially.
Thank you. And we have some other questions here, and hopefully we can help them. Jemana, will you pose the next question, please?
So the next question is by Brother Muhammad Yassin to Dr. Riza Zaidi. Please put some light on creatinine levels, diabetes, and fasting.
Yeah, thank you. That's quite a good question. I think more than creatinine, if I were living with diabetes, something what I would look at is something called the estimated GFR or eGFR. Creatinine can be influenced in a lot of ways. So I wouldn't say that is the best measure. I'm presuming the brother wants to know about kidney function or kidney damage with fasting. My suggestion would be the eGFR value, or the estimated glomerular filtration rate, would probably be the best measure instead of the creatinine. The IDF-DAR guidelines, the risk stratification, have laid out very well on the different levels of eGFR values and the scoring for that. So that sort of contributes to the overall risk stratification. The one thing I think we should mention is if you're on metformin therapy, type 2 diabetes, and if the eGFR is probably less than 45, the dose should be reduced anyways. And I think it needs to have a very, very close eye on the eGFR values through the Ramadan month. So I think eGFR is probably more valuable than creatinine.
Thank you, Dr. Raza, for that answer. And I would like to call on Dr. Syed Riaz Ahmed to ask his question, please. Dr. Syed Riaz Ahmed. Okay. The next question is for Dr. Mubarak Naqvi from Dr. Rita.
Yes. Hi. So about the first part of your question, Dr. Rita, the time for is starting the fast, that is suhoor, and the time for ending the fast, that is iftar. You are very right. They are different in different countries. It depends on the time of the sunset and sunrise, and it is calculated on the basis of that. So it is not only different in different countries, but it is also different in different times of the year. So since Ramadan follows a lunar calendar, so sometimes it can be in summers and sometimes it can be in winters, and that is how it is calculated. There are formulas for that, and that is what determines the timings. Regarding your second question, I'm based in Mumbai, and I don't practice clinical medicine. I'm more into research and development. I work for Sanofi, which is a French pharmaceutical company, and I'm heading their diabetes medical division. Thank you.
Thank you, Dr. Said Mubarak. So the next question is for Dr. Wahida Karmali from Sister Priyanka. She's asking how to incorporate snacks and how much water to take when breaking fast.
The amount of water would depend on each one, but I think it's good to drink the water as much as you're comfortable with. I think it's the comfort. You don't want to overload anyone with water. So just be comfortable drinking as much as you can. You typically, when you break the fast, you break it with some fluid and a date. And just to be careful about the number of dates one eats, because in the United States we get dates of all shapes and sizes. But if you take even a medjool date, which is quite a large date, it has 16 grams of carbohydrate, just one date. That's like having 4.5 teaspoons of sugar. So people have to be aware of that. And so the snacks could be 1 to 2, depending on what people want to have. So people do night prayers, so maybe that's a good time to have a small snack. And I think most people cannot eat more than that. People typically like to have one snack, and that can be done. Maybe 10% of your calories can come in that snack. So I also wanted to add one more thing too, because so much of metformin has been mentioned today. It's really important for patients who take metformin to check their vitamin B12 levels, because when you're on metformin for a long time, there is a problem with a B12 deficiency, and you can be anemic. So please make sure that your B12 levels are checked.
Thank you, Dr. Wahida, for that answer. The next question will be for Dr. Ali Asghar. Huma Kazmi has asked a question. I'm taking 20 milligrams of Jardiance and 500 milligrams metformin. I'm thinking of switching Jardiance after iftar and metformin after sahur. What is your thought?
Again, Yamal, I think, as I told in my presentation, metformin, we do not need any dose adjustment. Now, if the patient is on once daily metformin, you can take it at iftar, you can take it probably at sahur, it doesn't matter. Jardiance, which is an empagliflozin, an SGLT2 inhibitor, well, it is usually in this part of the world, we use it once daily in the morning. But in Ramadan, yes, I completely agree, Jardiance or empagliflozin, which is SGLT2 inhibitor, should be taken at iftar because it works more in the first 12 hours, and we do not want to give Jardiance or empagliflozin at seher time, and just that extra 1 or 2 urination can lead to more thirst and maybe dehydration. So I completely agree, metformin you can take at any time. You can take it at seher or iftar. Jardiance you should take it at iftar time only in my Ramadan. And also for all our viewers, Jardiance or empagliflozin should not be started in the last 2 weeks before Ramadan. It should be started at least 2 weeks before Ramadan so that the patient's body can get used to it, get adjusted to it, and it's very important. Just one point which Dr. Wahida fantastically answered, how much glasses of water should one drink? Now, this is a common question that in Pakistan people ask us. And to be honest, in all these years, what I've seen is diabetes patients have trouble in the last 10 days of Ramadan. These are the nights when people are awake, they are busy in ibadah, they are busy with the holy nights, and there it is when they do not want to drink a lot of water after iftar until seher, because they know that if they're going to drink water, they'll have to go for urination, they'll have to make wuzu again, and they try and avoid water in these last 10 nights. And what happens in diabetes is you've already passed 20 days of tough Ramadan, especially here in Pakistan, and Dr. Mubarak could agree in India, it's going to be a tough hot Ramadan this time. So the first 20 days are already gone, very tough days. The last 10 nights, people are already tired. They avoid to drink water because of the ibadat. And here it is that when sometimes we have to tell them how many glasses they actually need to drink in these last 10 nights specifically. And in our practice, we tell them, look, you have to take 8, 9, 10 glasses probably, of course, looking at the kidney condition, at the heart condition. So sometimes in this part of the world, apart from the comfort level, we have to tell them the glasses of water, because people's comfort is more with ibadat, and our comfort is to keep them safe so that they can perform their ibadat.
That's interesting.
Thank you very much, Dr. Ali Asgar. So the next question is by Mashouk Ali Dasti, and it's for Dr. Riza Zaidi. So he's asking, is there any difference in management of heart failure, diabetes mellitus, and fasting?
Sorry, is there a difference
So
between?
yeah, so is there any difference in the management of heart failure, diabetes mellitus? I
Oh,
think
right. So
as comparison to healthy patients.
right. Okay. So if one has heart failure with diabetes, there's a very high chance that they would be on a diuretic or a water tablet, typically furosemide, benraflumetazide. These firstly would increase the chance of dehydration, would increase the chance of, well, it increases micturition or urination essentially, and that's how they work. And eventually, if you're fasting and you're passing a lot of water, the chances of dehydration go up. Now, you need to take a step back and probably look at the risk stratification and see where they come in that really. So complications, macrovascular disease, heart failure would be quite highly scored. So maybe it's worth also discussing with the physician the suitability to fast in the first place. But if you are willing to fast, then this is the thing that I would be really wary of in terms of dehydration with diuretic therapy. Apart from that, I think breathlessness or symptoms of heart failure as opposed to diabetes on the own. Again, the advice would be not to do any strenuous activity which would worsen breathing problems anyways, and more so with people with heart failure as well.
Thank you, Dr. Reza. I'm gonna actually ask a question too. With the continuous glucose monitor, sometimes there are some discrepancies of up to 30 or 40 milligrams per deciliter. And there could be sometimes false low blood glucose readings on the continuous glucose monitor. Would you recommend patients who are fasting to use glucometers in place of CGM, or should they use it simultaneously, or what will be your approach?
Absolutely spot on. The validity of accuracy of continuous glucose monitoring is the lowest. The accuracy is the lowest with low blood sugars and really high blood sugars. So, less than 70 milligrams per deciliter or 160 and above, or so probably 200 and above. and you could argue that that is the reason why they are there in the first place, to pick up those extremes of blood sugars. My advice always is that if the continuous glucose monitor is telling you a reading or is giving you a trace which you don't think, so for example, if it's showing that you're going low, or it's given you a reading which is suggestive of a hypo, but you're not getting any symptoms which you would normally get, always do a finger prick test. And I normally suggest people carry their glucometer with them. I know it is a bit of a burden, but just keep carrying it, especially in the times of hypoglycemia. So, when in doubt, always check your blood glucose with a finger prick.
I also tell them to confirm it with a finger stick, because this is interstitial glucose that's being done by the CGMS.
Absolutely.
And finger stick is a capillary blood sugar, which is a whole blood, as opposed to the serum blood. Anyway, the second thing is that if they don't do finger sticks and they just depend on CGMS, the insurance will slowly stop supplying them the finger sticks, and you will have an upstream battle with them also. So one does not preclude the other. But I tell them that CGMS is a good way of having a continuous input about very subtle changes, particularly nocturnal hypoglycemia and postprandial hyperglycemia. I think once we get a feel of the graph, then you can automatically, subconsciously correct the error rate, and it then becomes a new norm for you if you use it long enough, I think.
Dr. Yamal, just a quick point, the very, very important thing of a continuous glucose monitor, which people don't pay too much attention to, they worry about the readings of the patterns, is the arrows that it shows. So it predicts where you're going in the next 15, 20 minutes. And that is, in my opinion, a very powerful tool to tell you which direction it's heading. So if it is, say, just borderline, are you going up, going down, or are you going to stay steady? That's something to probably educate patients more, in my opinion.
Down the road accidents can be avoided that way.
Absolutely. This predictive ability of continuous glucose monitors.
And I also found it very useful to do your own CGMS as a physician. It's remarkable how well you understand diabetes when you do the CGMS on your own, particularly if you are a non-diabetic. You will see the dawn phenomenon. You will see the insulin sensitivity points on the 24-hour scale. It's really an insight that all physicians should have.
Absolutely.
Yeah.
Thank you. And we have a time just for a couple more questions. Fahim would like to know the effect of weekly injections for diabetes and fasting, as with oral hypoglycemic agents. Are we able to adjust them easily? And I'll open this question to anybody, or Dr. Aliesker, if you would like to answer that question.
Yes, so I think the weekly injections, I think what we are talking about is the GLP-1 analog, dulaglutide, which is once weekly injection. Dulaglutide is a GLP-1 analog, and it should not be started in the last month before Ramadan. It should be started well before that time. And if the dose is going correct, you do not need any dose adjustment with dulaglutide, which is once weekly GLP-1 analog. The question as I read it is also about the oral medications which can be adjusted easily as against dulaglutide. So again, dulaglutide, we do not need any dose adjustment. It is once weekly, and in my Ramadan, it continues to be once weekly. For oral medications, now, for most oral medications like DPP-4 inhibitors, SGLT2 inhibitors, metformin, acarbose, pioglitazone, you do not need any adjustment. In some of them, like SGLT2 inhibitors, they need to be taken at iftar. Yes, sulfonylureas still very prevalent in this part of the world, Pakistan, where I live, because of the cost benefits. In sulfonylureas, we definitely have to adjust the dose, and the dose adjustment is very easy now. The iftar dose is the same as the dinner dose, and the seher dose is the same as the breakfast. It just goes to half of what is taken at breakfast, the seher dose. And the iftar dose is usually the dinner dose.
There is a recent introduction of a 1 week long-term insulin. I think Dr. Naqvi might be able to tell us. I think it was in the New England Journal of Medicine or somewhere that there's a weekly injection of a long dose insulin. So it might be coming, but I don't think it's available clinically.
Yes, so there are a couple of weekly insulins that are under development. One is with Novo Nordisk. There is another one at Sanofi. But both of them are in early phases of development, phase 1, phase 2. And there is still a few years before they can be clinically available.
Yes.
Thank you. So I have a question for Dr. Wahida Karamelli. When is the safest time to exercise during fasting in Ramadan? And if it's the evening time, what if they are on sulfonylurea or dinner time rapid acting, short acting insulin?
As you heard from Dr. Ali Asgar, and I think also from Dr. Mubarak, sulfonylureas, create a problem with hypoglycemia. So I'm not sure if they're going to continue during Ramadan with it, which can be problematic. But what's recommended is they're really not clear recommendations, but it seems to be preferable to exercise closer to iftar. So if you begin to feel a little uncomfortable, should be closer to iftar. But I would tell patients, not to go on a very long period of time with exercising, maybe do 10 minutes at a time during the day. And even walking around, cleaning your house, cooking, all that is activity. So that could be used as activity and not go into very strenuous activity. And I think you really have to be careful. But again, with technology, with continuous glucose monitoring, the prediction is there where the glucose is going, so you can stop exercising when you think you're uncomfortable, or do or just prick your finger to do the using a glucometer. But I think it's very important to be careful, and that's why you need to start before Ramadan. Try to plan your activity during before Ramadan, so that you can continue without problems during Ramadan.
Thank you, Dr. Wahida. Dr. Ahmed had a question. You had your hand raised, Dr. Syed Riaz Ahmed. If you'd like to ask your question. Okay, so we'll just ask the last question, and then we will ask the panelists if they have any final statements. The last question is from Dr. S.A. Zaidi. Would like to know one practical point. In the outside part of the world, most of patients have uncontrolled glycemic parameters on oral hypoglycemic agents. It's a good practice to start a second basal insulin to reduce glycemic toxicity during fasting. Any comments from any of the panelists, Dr. Raza or Dr. Asghar?
Sorry, I just missed the question. Can you just repeat the question, please?
I believe it's a comment from Dr. S.A. Zandi. He would like to point out a practical point. He says in the outside part of the world, most of the people have uncontrolled glycemic parameters on oral hypoglycemic agents. And it's a good practice to start a second basal insulin. I'm not sure if they mean to add on a basal insulin or add two insulins there. But in any case, their goal is to reduce glycemic toxicity. And I think what they're asking is, if anyone's on oral hypoglycemics, would it be better to change to basal therapy during the fasting period instead of worrying about the oral hypoglycemics during Ramadan and ingesting them?
So again, Yamula, I think the whole purpose of today's webinar was to just highlight this point that anybody who wants to fast should have controlled diabetes before they enter Ramadan. I mean, as a specialist in diabetes, we all would want to control diabetes before our patients would go into fasting. And if you ask me, there should not be any change in the last 2 to 4 weeks before Ramadan. I mean, this is the crucial time when the patients should get used to their current treatment regimen, and that's not the time to add another insulin. Now, if somebody is uncontrolled on oral medications, yes, in terms of controlling diabetes, we have to add another medication or maybe insulin. I mean, somebody who's on multiple oral medications, 2 or 3 medications already, definitely basal insulin or even premixed or basal bolus can be an option. But to actually start insulin and straight away move into Ramadan might not be a good option. I mean, in such situation, it should be very clearly discussed with the patient the risks associated with uncontrolled diabetes if the patient actually moves in with uncontrolled diabetes in Ramadan. And starting insulin straight away before Ramadan would not be a good option.
I agree with that completely.
Thank you, Dr.
It's a
Asghar.
very, very good idea that might be worthwhile to do it before, at least a month or two before, because these are long-acting insulins and they behave differently after 3 days or after 7 days or after 10 days as opposed to the first dose. So that's a little bit of a tricky situation. But as a rule, the basal insulin is an extremely useful device that I have seen to avoid polypharmacy and also unnecessary expense to the patients, particularly in the subgroup that I have the luxury of looking into it in a little bit more detail about the nature of type 2 diabetes. There's a significant group, particularly in the type 2 diabetics, who don't have the capacity or the ability to convert pro-insulin to insulin. Those are the ones that very beautifully can be controlled by a minimum dose of 10 to 15 units of basal insulin at bedtime. Yeah. But not everyone can do the pro-insulin, insulin, and C-peptide ratio. So.
Thank you very much. So before finishing up the discussion, I would like to ask if any of our panelists have any final statement.
Well, I would like to say something, and I would like to tell people with type 2 diabetes and who have the metabolic syndrome, you know, you can, if you have the metabolic syndrome and you haven't progressed to diabetes, you have a chance to work on it all year. So in Ramadan, you won't have diabetes. And we have studies done in the US and Finland that showed people, they compared metformin to lifestyle. They found that 58% of the people did not progress to diabetes if they followed lifestyle recommendations. In fact, it was even better than metformin group. So I would say, think of stopping diabetes, as the American Diabetes Association says, and look for ways where you can control your body weight and eat healthfully, because that has shown to lower your hemoglobin A1C from 0.3% to 2%. So try to do that before next Ramadan. Thank you.
Thank you very much.
Can I just quickly also add, in
Yes.
terms of people on insulin therapies, we stock up very well for food items in Ramadan. But I think one of the crucial things to do is for people who are on insulin, whether they're type 1 diabetes or type 2 diabetes, is ensuring they have enough stock of glucose strips, ketone strips, and, you know, in case of emergencies, especially in this part of the world where I come from, where everything's nationalized, it's ensuring that that stock is in check, and they've got that in stock as well.
We have not discussed glucagon emergency kit as a general discussion, but that is when hypoglycemia can occur. And I believe in an emergency that can be also a useful item to keep at hand. And the last thing is having an identification bracelet or some form of an ID that you have diabetes, particularly when you're fasting. That would be important. As far as I'm concerned, Ramzan is a very, very good way to understand nutrition and malnutrition, food distribution and food errors in food distribution. All these things have been highlighted with the advent of Ramzan. And it is a blessing truly to see not just obesity and plethora of food. We should also look at islands where there are very, very poor nutrition and lack of food, like Yemen, for instance. So we should explore that in our future of how we can restructure malnutrition from food deficiency to food excess. And that Ramzan seems to teach me every year this aspect of the blessings of Ramzan.
Speaking of glucagon kits and treating hypoglycemia, it's really important to involve a member in the family, teach them how to use it, teach them what to give you if you're running a low blood glucose. It's really very important to get that support in the family.
Yes.
Thank you. Thank you very much. This brings us to the conclusion of today's event, the annual International Diabetes and Ramadan Fasting Panel discussion. We wanted to thank our esteemed panelists, Dr. Syed Mubarak Raza Naqvi, Dr. Muhammad Ishaq Erastu, Dr. Wahida Karim Ali, Dr. Raza Zadi, and Dr. Ali Asghar. We also sincerely thank all of our audience for attending this webinar internationally from around the world. We graciously thank you, Shifa Abbas, for your hard work and diligence. We would like to show our gratitude to Haider TV for the live telecasting globally. And we also want to thank all the guests who have asked excellent and very inquisitive questions, which then has further enhanced the learning about Ramadan and fasting and diabetes. Please, in order to enjoy more of these events, please stay connected with the work that IMI does. Please visit the website, www.imamiamedics.com. Follow us on Facebook, Twitter, LinkedIn, Instagram, and YouTube. You can see the details on our website on the various projects of about 70 projects worldwide. And I'm going to now hand it back over to Ms. Shifa Abbas, our IMI's Global Coordinator, to say a few words.
Thank you so much, Dr. Yemal and Jamana, for hosting this session, and many, many thanks to all of our panelists. I just wanted to take 2 minutes of your time to highlight a very special project that's very close to all of our hearts here at Imamia Medics, which is our largest project ever, our dream project. As you can see here, we've had 25 years of excellence from the very first conference in Boston all the way to our Silver Jubilee events 25 years later with the 10th International Conference in Karachi and Islamabad. July of 2020 marked the fundraising campaign that was launched for our IMI Dream project. And at this point, we only have 0.75 million of our loan to repay to begin development on our largest project yet, which will take us from a donation-based model to one that is income and employment generating. We're establishing an intentional community located in Robbinsville, New Jersey, one of the largest populations of Shia Muslims in America. The investment projects for the intentional community include of the 30 acres that we've already purchased and are working to repay are an assisted living facility, skilled nursing facility, an inpatient rehabilitation facility, and senior living facility, all projects that are vital for the growth and sustenance of our own communities, as well as vital organizational projects that will help IMI continue in the 17 countries, 70 active projects that we have currently under our wing. It'll house our global headquarters, as well as our women and youth wing headquarters, a young leaders research center, a library, auditorium, and conference room, as well as be the headquarters for Medics International Virtual University and Imamia Television Network Studio, which will be launching later this year. So I would encourage you, $750,000 is very small amount for a community as large and vast and well established as ours. So I would encourage you to please find it within your hearts to help us meet this goal, to, in the short term, donate to our Ramzan appeal, and help millions of people across the world, across the five continents that we have our membership. And with that, I thank you all. Inshallah, we will see you all again, if not very, very soon, but definitely for next year at our annual International Ramadan and Diabetes webinar. Thank you so much.
Thank you.
Thank you so much.
Thank you. Bye.
Thank you.